Lateral thigh pain may be the patient's presenting symptom on occasion. It's typically not presenting in isolation. However, these patients often have knee or hip or groin or low back symptoms. Taking a good specific verbal history, especially with regards to what symptoms have been there, what symptoms are there now, what locations, what limbs, getting that information is very important for understanding the whole diagnostic picture. Lateral thigh pain is often attributed to IT band syndrome. I disagree with the pathophysiology of IT band syndrome. I don't believe that structure, which is the fascia or the tissue that makes up the bulk of the lateral or outer thigh compartment, is actually getting tight and producing symptoms. Possibly in rare cases, but I think it's way overdiagnosed and misunderstood as a causative factor when it comes to lateral thigh pain, as well as lateral hip and lateral knee pain. For lateral thigh pain, for that patient, I'm typically going to use repeated movement testing as part of my orthopedic exam. Using the Ober test, as many clinicians do for the lateral thigh, is not a good diagnostic tool, although people believe that it is. What I would use more diagnostically is repeated movement testing. I'll look at either repeated movement testing of the low back or the hip joint first. In rare cases, I may look at repeated movement testing of the SI joint on that side. But if the patient is presenting with just lateral thigh pain, I'm likely getting an inclination from the verbal history and the baseline taking that it's from the back or the hip joint. My algorithm in my head that I use for patients' complaints is to think of the spine out or the spine down. So I'm typically starting my algorithmic testing or my investigation at the spine, but if something in the verbal history or something in the baseline taking rules out the spine or makes me think that the likelihood of lateral thigh pain is more often or more likely to be coming from the hip joint itself, I will start my testing at the hip joint. It's much more common for me, however, to start my testing at the low back because of the high prevalence of the low back referring symptoms into the thigh, including the lateral thigh. Now, the L4 and L5 nerve roots coming out of the lumbar spine, the L stands for lumbar or low back, those cover parts of the lateral thigh. So there could be strict nerve root irritation or obvious nerve root irritation that's causing the lateral thigh to be affected. More often though, it seems that the pain from the lumbar spine, if it's going into the lateral thigh, is more simply referred, not traditional or more kind of obvious nerve root irritation to a specific nerve root like the L4. Referred pain from the low back often goes into the buttock and into the thigh, sometimes down to the knee, although when you're getting patients with complaints below the knee, it's often more radicular in scope in terms of actual nerve root compression and presenting with more sensory disturbances like numbness or tingling versus just pain. So my lateral thigh patient, I'm typically going to be looking at the spine first in the third part of my orthopedic evaluation when I do testing. And based on the verbal history and the baselines, we might look at spine extension or side gliding or rotation inflection or flexion. It all depends on what I've heard and what I've seen. Now, in part two, when I take the baselines of a patient with lateral thigh pain, I'm going to be taking the 4 motions of the low back, of course. I'm also going to be looking at range of motion, probably passively, but maybe actively as well for the hip joint, into flexion, internal rotation, external rotation, extension. I might look at a few other ones, and then I might look at, since I'm in those positions, I might look at a Fader or a Faber test, which is a combination of movements at the hip. Fader stands for flexion and adduction and internal rotation. Faber stands for flexion, abduction, and external rotation. Those are specific moves of the hip to give me not a diagnostic answer, but an idea of how the hip joint is moving, and especially if it creates lateral thigh pain when we do it. Also in the baseline testing outside of range of motion, I can look at nerve tension. We can look at the sciatic nerve in a supine passive straight leg raise test. We can look at the femoral nerve, which goes more to the anterior thigh, but sometimes it could, present with a little bit more anterolateral symptoms. We just want to make sure that there's no compression of the femoral nerve by doing a prone knee bend test. Prone knee bend, seeing how far that foot can go towards the patient's buttock. Outside of range of motion and nerve tension, I will also look at strength. I'm typically looking at hip flexion strength in supine, hip abduction strength in side lying. I may look at hip internal and external rotation strength in sitting or in supine, and I can do hip extension strength in prone. I don't tend to do that one as much, but I can always add it to my evaluation as time progresses if I need to. You could look at knee stuff, meaning knee flexion and knee extension strength in sitting. I'm probably, in the interest of time, not going to be looking at stuff above or below the distal thigh in my exam, but I may, especially if I really consider that there's a spinal component, I may also look at, for example, dorsiflexion, plantar flexion, and toe extension to see if there's more evidence suggesting that this lateral thigh pain is part of a problem in the low back, which is not only creating the lateral thigh pain, but also creating myotomal weaknesses in the lower extremity below the knee. So those are the main baselines. In terms of nerve tension, range of motion, and strength, I will try to get a functional baseline like with any patient, meaning asking the patient, is there something we could do here in the office that would be provocative for your lateral thigh pain? Maybe it's a squat, maybe it's a step up, maybe it's rolling over in bed, maybe it's hopping on one leg. I'm trying to look for that because I really want something that we can use in the office, if possible, to do our cause and effect testing. Repeated movement testing is cause and effect testing. Other types of tests in orthopedics are not. You don't say, hop on your foot, and if it hurts your lateral thigh, let me know. Take an x-ray and then retest the hopping. That's not how an x-ray works, obviously. But a repeated movement test, we can move the hip in a certain direction or move the lumbar spine in a certain direction and test the effect on the hopping immediately to give us an idea of whether we're onto the right movement or not. I think of repeated movement testing as kind of a living and breathing test. It's really functional in that regard. It's letting me know what happens to the body when we do a movement in this direction repeatedly. As I say over and over, your joints are moving thousands of times per day, so we need to challenge it with at least 10 repetitions, probably a little bit more in the office. In the interest of time, we need to know if a small number of repetitions has an impact. But over time at home is where we get the real valid data, because you'll get hundreds of repetitions, which is still nowhere close to the thousands of times you'll move in other directions likely. But getting to end range helps make those movements more kind of aggressive and deliberate. So for this patient, we may look at repeated movement testing of the low back, like I said, in part 3, maybe in the hip. Outside the motions of the low back that I mentioned, in the hip, we could look at repeated extension with internal rotation, which is a combo movement, repeated internal rotation. We could look at a variety of different movements for the hip. There are combo movements. There are different loads, whether you do it in supine or loaded with weight going through the limb. There's lots of different repeated movement tests. My job is to understand how repeated movement testing works and what is the most fruitful thing to test for the specific patient. How I make that decision, of course, is based on everything in the evaluation. Now, sometimes lateral thigh symptoms can be due to a peripheral injury to the lateral femoral cutaneous nerve. However, that's not typically presenting with pain. It's more of a sensory disturbance, like numbness or tingling. Once I was on a long plane ride and I got up, and that night the lateral part of my thigh was very numb, and I ruled out that it was my spine. I did some spinal movements, and I quickly, after a few minutes, was like, no, this is not my spine. I think it was peripheral. I think something kind of superficially got irritated, and that's why the nerve is presenting with that numbness and tingling. And I told myself, if it doesn't go away in a few days, then I'll investigate further. And it did. So lateral thigh symptoms can come from other things. They can come from, obviously, blunt trauma to the IT band, or trauma to the hip or the low back, or things that are not derangement-like, things that are not joints that are tweaked, referring pain to the lateral thigh. Those are not all disorders. There can also be other disorders of the spine and the hip joint. But I want to reference that looking at the spine and looking at the hip joint, looking at those two areas of joints and possibly the SI joint, is where I'm thinking first if someone just says, I have lateral thigh pain, before I go into those are the first locations I'm thinking of before I even get to, well, what's the diagnosis at that location? When I think about a patient's care, I think location, diagnosis, direction, and force. So location first, where do I think this problem is coming from? Secondly, diagnosis. Do I think it's a mechanical problem that we can fix with repeated movement in a specific direction or not? Is it cancer? Is it infection? Is it a broken bone? Is it structural compromise like a torn labrum, or a structural compromise like a herniated disc that is not amenable to movement, or a structural compromise like a very arthritic joint? And then direction and force, 3 and 4 in that thought process, are going to be, if it's something that's amenable to movement, which direction of movement and how much force are we going into with that movement? So the big picture is, please don't just think your IT band is tight. You can spend many months possibly rolling out the IT band in this effort to make it longer or looser, and I think that's almost always barking up the wrong tree. I would look at repeated movement testing of the lumbar spine and the hip as my probably top 2 tests if there was no obvious trauma and structural compromise. Repeated movement testing of the lumbar spine and the hip are highlighted in Robin McKenzie's books, Treat Your Own Back and Treat Your Own Hip. They are, for the layperson, they are not comprehensive. They do not include every test, and they do not really offer clinicians' opinion into which test would be most effective to trial first. However, they are great places to start. They are great resources for the person at home who wants to try to self-assess and self-treat.